Welcome, everybody. I know we have a bunch of East Coasters, Midwesterners, West Coasters, some Canadians, some doctors from Mexico. So really appreciate you all sharing your night with me. I promise tonight's about making you think. And really, I just love this course. I just think you're going to see how we can really raise our bar for everyday caries diagnostics. And I'm just going to dive right into it. Save your questions, or you can type your questions. We'll get to them at the end of the course. I want to start off with something really kind of that's been my mantra for literally decades. I teach geriatric dentistry. I don't treat children. In fact, I can't stand them as patients. And I just want everybody to read this, because to me, the fact that we have patients now living into their 90s, even into 100 plus, the longer we keep patients' tooth structure, the better the opportunity for total tooth survival. And really, it comes really hand in hand, not only with being a good dentist, but really about diagnostically seeing things far better and using your minds to think about what's best for this patient. That's really what tonight's all about. So I'm going to start really tonight with a Facebook post. I'll start it off in a kind of a jovial way, but this is a Facebook post from the dental community, and the doctor was asking the group for advice. So this came up last month, and let me dive into this a little bit more. So here's the x-ray. And the dentist says, looking for a consensus on treatment philosophy. Patient is 14 years old, and we've been monitoring small enamel lesions for a few years, which means they've just been watching, and they've been watching them get worse. So now the anonymous member says, this tooth obviously has progressed on the distal. I'm planning a DO, but also considering an MOD due to the enamel lesion on the mesial. Looking for guidance, if better to leave the mesial alone, I guess watching and monitoring again, or if the tooth is frozen, numb, does it make more sense to do an MOD? Thanks for your wisdom. And it seems like a simple question, but I'm going to tell you there is no simple question in dentistry. So I'm going to take just a few of the responses from this post. So Abel wrote, where there's smoke, there's fire. Daniel contributed, my philosophy is take care of suspicious areas if I'm already treating the tooth. MOD for me. 92 likes. So you start to understand when you're doing Facebook that obviously there are a lot of doctors who are supporting that philosophical approach. Is that your philosophical approach? If it is that you believe drilling is the more conservative way of treating a patient, this course may not be for you. Because again, drilling is a surgical intervention into a tooth. Margaret writes, extension for prevention when warranted. Cord writes to Daniel, yep, this. My feeling is, wasn't this what G.D. Black taught, extension for prevention at the turn of the 20th century? Well, we're in 2025, and I'm just trying to understand this approach. And it's not just this group. Restore the entire tooth at one time. MOD for me. Here we go again. And happens every other day. So these are people who obviously follow this philosophical approach that maybe drilling is a preventative way of looking at things. But then you go to a different direction, and an anonymous member gets 80 likes who says, I would never drill the mesial of this tooth. 12 more likes. This is the correct answer. And Zach writes, I would do a DO and treat the mesial with SDF and good oral hygiene instruction. Well, what I can tell you is that if this is a non-cavitated lesion, SDF is not the right approach. Nothing against Zach. So it's really understanding. And tonight I'm only going to get into what I call a full day lecture, or tonight a full day lecture that couldn't really encompass all of this. But I just wanted to start you off and going that when you look at the bottom line, far too many of us or our colleagues are way too subjective in our approach to caries management. So when I put this original slide up, or image, I should say, do you think that if 100 dentists evaluated these three teeth, that they would come up with the same caries diagnosis on how to treat them? I would tell you the chances are zero. Zero. And what does the literature say regarding dentin involvement in black and brown stained grooves on teeth? I think this will startle many of you. So many of you are going to be very surprised at the literature, which I will show you right now. The literature says basically these aren't usually filled with strep mutans or lactobacilli. These grooves are filled with actinomyces, a species of actinomyces. They're actually lower in cariogenic, they're just lower in creating caries. And black and brown stains, actually the patients have higher calcium concentrations in their saliva and they have a higher buffering capacity. So actually, black and brown stains are not indicative based on years of literature. This was just one of the many articles that I found. So how accurate then are vision and explorers for evaluating non-cavitated occlusal surfaces of this quadrant of teeth? Another article. This is from Lucy, very renowned researcher. And this is probably from the late 1990s. Look at the numbers. Vision is about 12% accurate for sensitivity. Vision with loops is better, it's 20%. Vision with light probing, meaning I guess maybe an explorer barely touching it, is 14%. So when you start to understand this, let me define sensitivity. Sensitivity would mean if there are caries there that are going into dentin, that if you do a test and you are 100% sensitive, that means you are 100% accurate, knowing there's disease there. So basically, these are very, very low numbers. So let's say you get a stick. Do you need better diagnostic for the molars, or because you didn't get a stick, that then you're just going to watch these? And a brand new Explorer based on Lucy has an accuracy of barely 50%. So it's like flipping a coin. How accurate then are X-rays for evaluating the proximals of this quadrant of teeth? Just 2D X-rays. So let me also say it's like flipping a coin. Digital sensors have really not increased caries detection rates. And the literature, you can just Google it. There's so much literature on this. And it basically comes down to that standard bite wings can diagnose 60% of proximal lesions into dentin. 60%. So we're just guessing with explorers and 2D X-rays. So here's an article about non-cavitated interproximal caries. How accurate? If we're talking just enamel caries, enamel, so demineralization of the enamel, sensors were actually less sensitive than film and phosphor plates, only 15%. And we're talking enamel demineralization. This is an example of 2D AI with Pearl. I'm a big Pearl guy, and I believe in both Pearl and Overjet and AI in general. And here the little yellow areas is what AI has identified as interproximal incipient lesions. Well, what about dental caries? Sensors are only 45% according to this study, not even 60%. And obviously, here's 2D AI with Pearl showing you caries that have penetrated the DEJ. And the studies are now showing that AI in general, 2D AI, has an accuracy up into the mid 80s. And so when you're looking again at the word sensitivity in AI algorithms, they up the game of 2D imaging from at most 60% accuracy in dentin interproximal decay to the mid 80s. So I will only tell you, and we're not going to get into 2D AI tonight. 2D AI is an absolute must. We've had it now 4 years in our practice, and I can tell you, you only can see 30 to 40 shades of gray. AI with Pearl and Overjet can see 500 to 800 shades of gray. Let's get back to this image. And do you really think 100 dentists, as they evaluated these 3 teeth, would come up with the same preventative approaches for this patient? Again, I think it'd be far too subjective. So when I look at prevention for non-cavitated E1, which means early enamel caries, or E2, deeper enamel caries, the options for years have been flossing and brushing. As you look at all of these areas, you can go to high fluoride remineralization pastes and rinses, hydroxyapatite toothpaste now, remineralization trays, and those are all based on patient compliance. And we all know half our patients won't follow our instructions. And then you have to then start to include, how does varnish fit into this? Do dental sealants have a place? Personally, I don't believe in sealants anymore. Icon was a great procedure, but difficult. SDF is really for cavitated lesions. And I think the game changer, which we'll touch on tonight, is cure, not repair. So tonight's course is really about coming up with diagnostics that are really more sensitive. If disease is present, how did these diagnostics find the disease and tell you that we have disease, and how are we going to treat it? It's about individualizing your patient's care to caries detection, diagnosis, prevention, and then how do we monitor these patients? The bottom line is dentistry is one of the most subjective professions. You put 5 dentists in a room, you get 10 different opinions. We have to decrease our daily subjectivity. That's my goal tonight. So my philosophical approach since graduating dental school, I won't get into it in depth, was always to be minimally invasive. Save as much enamel as you could. And yet, when I graduated dental school back in 1982, probably before some of you were born, I can't stand that idea, but it is what it is. But when I graduated, what did I have? I had an Explorer. We didn't even have loops, and we had film. And basically what I just showed you is we were just guessing. And throughout my career, early career, I would find big holes in teeth. I drill. I think there was nothing there, and my burr would just drop in. I take out an occlusal amalgam, nothing on the X-ray, and all of a sudden I've got interproximal caries. I couldn't see it. Wasn't diagnosing. My technologies were not diagnosing. So circa 1920s, diagnostics, the era of the dental explorer. So that's the birth of the dental explorer. Circa 1950s, X-rays. X-rays were really introduced mainstream in the 50s. Yeah, they were around for 50 years before that. But per all the literature, insurance companies only started accepting X-rays, and that was the big boom in the 50s. So What happened to explorers? Why are they not diagnostic anymore? I'm just going to show you one quick diagram. Pre-1956, when fluoride was introduced into the water in Grand Rapids, Michigan, and a 10-year study was done, we didn't have fluoride. And I won't get into the debate of fluoride, but you'd have cariogenic bacteria release their acids, go right into the fissures, and then laterally spread. Fluoride today remineralizes the fissure, but you still get acid breakdown and demineralization happening through the fissure. But an explorer, it's not going to be able to get that stick like it did in the 50s, 40s, et cetera, et cetera. But you're still going to get that lateral spread. So all too often, dentists are surprised when their bird just drops into a huge hole because they didn't see anything. X-rays didn't show anything, and the explorer didn't get a stick. It's happened to all of us. So why do we need additional tooth diagnostics? The first thing is you have to realize X-rays, even with AI, they are evaluating tooth structure two-dimensionally. That's what they're doing. Explorers, they simply are that. They're just exploring. So both of these have low efficacy. As far as sensitivity goes, AI has upped the game tremendously for proximal lesions. But again, it's 2D imaging. So in the 80s, the first breakthrough, I mean, you guys won't believe this, we'd spend $5,000 for an AccuCam intraoral camera, because if we could take pictures, we could, and this is really before we had loops that were 4, 5, 6x, we could see more on a camera. So we would use this to present to patients and for ourselves to look at teeth a little bit more carefully. Over the next few decades, this is what I used. I used Diagnostics. I think we had 3 of them in our office. We had Spectra in our office, and we had CaryView. I launched CaryView, I think it was with Dexys, back around 2014 and 15. The first month we had CaryView, I'm just going to share this with everybody. The first month, we found over 52, I'll never forget this, 52 interproximal carious lesions into dentin that were not on X-ray. And I'll show you one of them. And this is why I knew we needed more stuff. And I'll share some of this case history with you as we go tonight. But here's the bottom line, and I call it the cycle of tooth death. As part of that Facebook post, many people just watch and wait for the caries to occur. It's just a wrong approach. How do we become preventative versus watching and waiting for the caries to occur? Or, again, I think it's the wrong approach, drilling early lesions to prevent them getting bigger. I mean, as soon as you put a class 2 composite in, it starts to break down. It may take 5, 10, 15 years, but those margins, they're going to start to break down. And in high-risk patients, they're going to break down faster. And as you follow the cycle, as you read it, you're re-drilling, then ultimately a crown, then a root canal, and then ultimately, potentially, patients lose their teeth. So as we look at this, we have to think, how do different preventative approaches really fit into this cycle? How do patients' risk factors fit into this? How does a patient's home care fit into this? And then what diagnostic approaches are best for early detection? And what diagnostic approaches are best to evaluate success? That's really the core of the challenges I want to share with you tonight. I'm just trying to build the story so you start thinking with me, we all have to do better. So when it comes to diagnostics right now, there are about 6 hot areas, and 2D AI is absolutely one of them. Tonight, I'm going to focus on transillumination and fluorescence. Obviously, I've been working with these technologies for decades, and I think the simplicity has gotten much better, which I'll share with you tonight. I absolutely believe salivary testing and genetic testing, all via saliva, will become pivotal in recall appointments, which I call oral healthcare appointments. And there's a new company out with pH testing where you can actually test interproximally areas that you're suspicious of if they've got a pH below 5.5. Let's talk about transillumination first. And I'll tell you, it's all about the wavelength. And specifically tonight, we're going to talk two wavelengths, and I'm going to explain it, the red and blue wavelengths. So when you talk about the electromagnetic radiation field, or EMR, we have visible light. And that's really the smallest section as you look at this, electromagnetic radiation field, all the way from whatever gamma radiation to radio waves. Well, infrared light is the light found just past what is visible to the human eye. And infrared light is broken up into three different categories. Near infrared light, which is what we're talking about tonight, near infrared light. Then you have mid infrared light and what we would call far infrared light. All we're going to talk about tonight with transillumination is near infrared light. And it is the closest to visible light, but you can't see it. You cannot see near infrared imaging. So we're going to put a new term out. The term we're going to talk about tonight is NIRT, near infrared transillumination. So this was Carey View, and I am going to show you now what's going on with Diagnostics and how, to me, I think this is still one of the most, if not the most valuable way of evaluating interproximal and occlusal lesions. So this is really how it works. You have two silicon flexible fiber optic paddles. They do not hurt. They will basically cradle the tooth, and they will emit this NIRT, this imaging, from both the buccal and lingual direction. You will literally take the silicon pads and pass them down along the root structures, buccally and lingually. And so what will happen is this light at 850 nanometers will travel through the roots and upward to illuminate the tooth. Then there's a camera that will actually capture the pictures from the occlusal surface. And what I can tell you is, and I'll continue to refer to this, this is a 3D video image of a tooth. So here's it in motion. And obviously you can see the lesion interproximally on the bicuspid. That's the darkened area. Let's go further posterior. There's a composite, an amalgam, and interproximal also lesions. So now all of a sudden we have a way three-dimensionally of looking at tooth structure in a whole different way. I want to show this because NIR or NIRT also can be found, for example, in other devices. So I have an iTero 5D, and as I take my magnifier and I put transillumination or NIR or NIRT through it, you will see that instead of a dark interproximal area, you see actually, which would be pathology with traditional transillumination. The iTero scanner basically sends light from the scanner head. It's not coming up through the roots. From the scanner head, it hits the area, engages the tooth, and reflects upward. And as a result, it's more of a reflection than a transmission. And this is a key differential. This is two-dimensional. So when I'm using this versus, I'll say, the Diagnostics, The Diagnocam gives me far more information. But if you have an iTero 5D, at least you start to understand that you're seeing teeth with basically transillumination. So when we look at transillumination, it's really, again, 3D visualization. So here's what happens. The wavelength, the infrared wavelength, is longer than the crystal structure of hydroxyapatite in enamel. So actually the wavelength passes through it, and enamel, healthy enamel, will appear light. And so this is light. And I've got plenty of cases to share with you. Healthy dentin does not transmit the wavelength. And as a result, the dentin will appear somewhat darker. Not necessarily caries dark, which I'll show you in a few minutes, but the dentin is always darker because A, it's not hydroxyapatite, obviously, and it's just a different light transmission. So what happens? So what happens is that as a tooth starts to demineralize and the enamel degrades, the photons of the light start to scatter. And what happens is as they scatter, the area will have a darkened appearance. Amalgams can have a dark appearance. Gold fillings or restorations can have a dark appearance. But I'm going to show you pathology based on the scattering. So again, in normal transillumination in healthy enamel, it will just pass through, it'll light up. It's the dark areas that we're concerned about. So here's an image, but I want you all to realize the transillumination can be used, and I'm going to show you this, for initial occlusal decay, initial proximal decay, and smooth surface decay. But it also shows, like in this case where the red arrows are, secondary caries around an old amalgam, and it will also show cracks and craze lines. Why? Because the enamel has been altered, so the photons of the light are scattered. So I first want to start with understanding occlusal decay. When do you drill? When do you use Curaden? So on the far left is early occlusal decay. It's not dark yet. Would I be drilling on that? That's where I'm using a visual aid. I'm using fluorescence, which we'll get to. Advanced occlusal decay, now it's getting darker. So understand, as the light's passing through the enamel, this is showing me a depth that there is definite dentin caries where it's very, very dark. On the far right, you have a fissure that is dark. And then all of a sudden you start to see a lateral spread, kind of a not as dark an area, maybe more of a white spot lesion or an opacious lesion. But this is what you get immediately when you transilluminate. You're not guessing. So there are three ways of looking at early decay, advanced decay, and then fissure decay. I want to talk about cracks. So this is a tooth with a couple old amalgams, and you can start to see whether they're cracks or craze lines. You can start to see them. This was one of my patients who came in with chewing sensitivity. The darker area superficially is recurrent caries. Below the composite, you can actually see a crack line running on the occlusal floor. For this patient, what we did was we put her in a temporary crown to see would that take care of her chewing sensitivity, and it did. She didn't need a root canal, and the literature shows you need full cuspal coverage when you have chewing sensitivity with a fractured cusp. This was a virgin tooth that came into our practice. And again, she could not bite on the lingual cusp. Now, you cannot tell the depth of the crack here. It doesn't give you a depth reading. but it's as clear as day that you have a mesial to distal crack. And if she can't chew on that tooth, you're not putting a composite on that tooth. You're going to put her in a temporary and see, did that cure her problem before you do a final restoration? And again, if it didn't, and let's say the crack did go to the nerve, she'd have more of a different kind of pain. But I put her in a temporary just to make sure her pain was alleviated. Once it was, we went to the permanent crown. So throughout my career, I can cite so many cases. This is Mikkel. She came in, big grinder. She couldn't chew on tooth number 18. And the distal lingual cusp was incredibly sensitive. So we put a tooth sleuth there, and upon her biting down and then releasing, she kind of jumped out of the chair. We did a vitality test. It was like 32 or 38, whatever it was vital. Took a periapical. There was no pathology. I would ask you, what are the chances of Delta Dental paying for a crown or MetLife with this image? And the answer is good luck. They're never going to pay. So I knew that. So we took an intraoral picture after we took out the alloy. Then we took a transillumination image, and look at the detail of the transillumination image. You can see the crack from the distal marginal ridge going along the distal lingual cusp coming out the lingual. So what do? You send the insurance company a letter. I misspelled tooth sleuth, but I was basically saying the tooth was vital and sensitive to chewing release. The first image is transillumination with the amalgam in. The second image that went out was obviously with the second image with the insurance letter was obviously with the amalgam out. How do you build value? You build value by doing this for your patients, and 4 weeks later, she got a check for the $872 for her copay from MetLife. You don't think she's happy with me? We did the right thing, sending the right information to the insurance company, and her follow-up was fine periapically. When you start looking at what we can do better, this was an article that I got permission to show some cases from Marwa. I actually got the email 2 days ago, and I love this article. The research study was about NERT compared with radiography to detect proximal caries. So is it better to use transillumination or x-rays? Well, NERT, again, transillumination, detects proximal enamel caries at an earlier stage than bite wings. And I'm going to show you all this. The study showed that you get 4 times more diagnosed enamel lesions versus a traditional bite wing x-ray. You can see it on the bottom of that screen in the red circle. That's an E1 lesion, an E1 early enamel. NERT also enables clinicians to differentiate lesions limited to the enamel. Also, then, once they've reached the DEJ, look at this image. This is my patient, Nicole. She presented with 7 lesions on transillumination. You can actually see the lesion penetrating the enamel and now laterally spreading along the DEJ. And this gets just so predictable of why we use this on our patients. And then you talk about another conclusion of this article was monitoring. So now we can monitor our patients far more closely with no radiation than just taking 6-month or 12-month follow-up x-rays if we're following or monitoring. But for me, this is where Curanon steps in, and we're going to get into it. Curanon's a game changer. We've been using it for about a year in our practice, and I'm going to show you 2 research articles and how transillumination really allows you to see things earlier and be far more preventative. So E1 is early enamel breakdown. E2 is deeper enamel, we'll call it demineralization. Both of those are what I call the window of opportunity for Curanon, which I'll get into briefly. Pearl, as shown in the image here, identified 3 early incipient lesions, all that should be treated with Curanon, period. And why would I say that? I say that based on 10 to 15 years of research about Curanon. It's been in Europe for 10 years. This one particular article, in comparing it to varnish, found that it was 80% successful in 6 months. 80%. The study show it actually becomes more successful month over month up to a year. In gray, you can see the varnish was only 34% successful. And varnish can only penetrate about 70 microns, toothpaste about 20, SDF about 25 microns. Curanon penetrates through the entire non-cavitated lesion. I also found it interesting that they used fluorescence, which we'll get to next, to evaluate the caries regression. One more study on Curanon. And again, I will just say this to you, I didn't have this in 1982 or 92 or 2002 or 2012. I didn't have this. This is a game changer for every one of you in your practices. This study had 405 lesions, adolescents, well, 10 years old to 19. These were all proximals, but you can use Curanon on any surface. These were non-cavitated proximal lesions followed on X-ray. In our practice, we would only use transillumination to follow them. Why? Because it's more diagnostic, which I will show you and continue to show you. Only, we'll call it 7% of the lesions progressed after one Curanon treatment. Only 7%. I find it hard that we have 93% success in almost anything else in dentistry. But here's a key point. 60% were arrested, meaning they stopped growing. So if you take transillumination every 6 months or a year, recall visits, and evaluate, you have a much better chance of imaging those lesions. And an arrested lesion means it's not growing. 40% of the lesions in this study regressed, which means they started to go through remineralization. Some may go through partial remineralization, some may go through full remineralization. It doesn't matter. Anything that stops growing is successful. That's how I would look at it. The key is you have to do early detection, because if you're using traditional x-rays like I've already shown you tonight, you're not going to see the enamel breakdown or the demineralization in most E1 and E2 lesions. So really, transillumination raises that bar for all of you. Now, in that same article comparing transillumination to bite wings, they said transillumination was as reliable for D1 lesions into early dentin, D2 lesions into medium depth dentin, and D3 lesions into deeper dentin. So this is what I call the event. I'm working on Jim here, an art dealer in Chicago. It's amazing how you can remember this, and I can't remember yesterday in general. And you look at tooth number 20, and you see nothing. His caries risk is moderate. He's got a bunch of large composites I've done on him. And in 2015, we're now incorporating transillumination carie view into the practice. You see nothing on tooth 20. There's your transilluminated image on tooth 20. It tells you exactly where proximally to drop your box. So here's the clinical picture, beveled margins, final outcome. I know it's only a class 2, everybody. I understand that. But when you think about it, Look how deep this was. Now you look at the image, the x-ray on 2015, you don't see it. So if I didn't have transillumination, this would have become a deep cavity, and he's coming in year after year. And don't you hate that, doc? How did I get a deep cavity when I've been coming every 6 months? So again, transillumination for me since 2015, key. So let's just look at, I love this, and I got permission to show this also. This is how we can monitor. So here, there was no treatment done. They were watching. And what you can see is interproximally the lesion getting bigger. You're not going to see this on an x-ray like this. 2D AI will help, but 2D is a whole different story. If you look at the occlusal lesion, you can see how that's getting deeper. So you know it's active, it's getting darker, and it's spreading laterally. So you know you have active lesions. For the top one, I would cure it on. Why? Because I don't know if it's to the DEJ yet. If it's not cavitated, I would try cure it on. For the bottom one, I think I'd have to do a small preparation because it already looks deep enough to me. What doesn't transillumination cover? I can tell you, I teach geriatric dentistry. Geriatric patients get cervical caries all around the necks of their teeth. It's just where the food accumulates. It's where the bacteria accumulates. Transillumination really does not capture what I call cervical caries. It just doesn't. You're going to need an x-ray for those areas or visual. Just sharing, there is a limitation with transillumination. Let me just show you a couple more cases on this. This patient came in with caries on a molar. I dropped a class 2 box, and this is what I found. You've all been there. Every one of you have seen this. You drop a box, and all of a sudden, proximally, you look at this, and now you go, should I just drill into it now, not drop a box, and come from it laterally? Well, look at it carefully. You've got one dark area, 2 dark areas, and then you have demineralization in a chalky white area. You're gonna drill a lot into this tooth. If you transilluminated it, there was nothing on the x-ray. That's why I'm not showing it. Here's the transillumination a little pixelated. And potentially, if I can't get an explorer into that lesion and it's not cavitated, what I would do is I would tell the patient, I want to avoid drilling on this tooth. It's going to cost you $100, and we're going to follow it with transillumination. And if it doesn't grow, we don't have to drill on it. Would you like to do that? And you think about it, what patient in their right mind wants you to drill on them versus being conservative? So now you have a way of being conservative with a huge success rate, and you can follow it without radiation. So this article came out regarding kids' teeth. I don't see kids. But once again, it showed the accuracy of Diagnocam with a higher sensitivity and better accuracy than bite wing x-rays in cavitated proximal lesions on primary molars. So again, minimizing radiation. In my own practice, when I'd be working on teenagers, I would go to the parent and I go, I'm not going to x-ray your child. I'm actually going to just use a different imaging. Why? If you've got a 17-year-old in your chair, you're taking bite wings, and if transillumination is more accurate, why would you radiate the kid? And the only answer is for insurance. So if the parent, because the transillumination at this point is still not covered under insurance. So with that being said, understand that's what we would do. We would, if they wanted us to take x-rays, we would take the x-rays on the kids and still transilluminate it, no charge. If they didn't want x-rays, we would transilluminate and store all the images in the patient's chart. And again, study after study, transillumination is less subjective than x-rays. Study after study. The other topic is fluorescence. And I've been working with fluorescence for 30 years. And basically, the tooth's going to absorb light, energized light. And it's diagnostically in either the red, blue, or green family or wavelength. And the structure, the tooth structure, basically, we're evaluating whether we have early stage decay. That's what we're trying to evaluate. So basically, healthy tooth is going to fluoresce a different color than decay or demineralization. And we use this fluorescence because this would not be visible to the naked eye. As a result, I can tell you, after 25 years of using Diagnostic and Spectra, I was far more accurate, not 100%, nothing was 100%, but far more accurate in my diagnostics than Vision and an Explorer for occlusal decay. So what will happen is basically the healthy part of the tooth is going to emit a green look to it. Areas of demineralization are going, or I should say decay, are going to turn red. Routinely, they'll be red. And that is from bacterial byproducts called porphyrins. They are made in, basically, it's the bacteria releasing their acid, and these are byproducts. They will absorb the energy, and what they do is they basically fluoresce in a different pattern, which comes out red in appearance routinely. And as a result, the green fluorescence of a healthy tooth is lost, and the porphyrins are releasing a red hue. And I'll show you a couple of pictures, of course. So these devices can capture various ways. First off, it'll just show you green versus red. That's a color differentiation. Or you could get a visual map like in Spectra. Or you can get an audible sound or a numerical score like in Diagnostics. All of these help the dentist identify and quantify. The far left was my original Diagnostic, then the middle was my next version, and today there's the Diagnostic pen. It basically is a red fluorescent light that penetrates approximately around 2 millimeters into the tooth structure, and an audible sound and numbers will be calibrated as the decay or demineralization is deeper. What I'm going to talk about more so now is blue fluorescence. And blue fluorescent operates in the blue violet area around 400 to 450 nanometers. It will also produce with porphyrins a red luminescence and green natural tooth structure that is healthy. So here's a perfect case that I got from Cavo. These are potential caries fissures. It will not give you a numerical depth. I'm going to use transillumination, which I will show you afterwards, how we put it all together. In this case, we have potential porphyrin issues in the fissures, but here I'm doing a class 2, or the doctor's doing a class 2. He's dropped a box, and you can see the decay. That's the red. So you can actually use this device as you're drilling to remove the decay, and then you can evaluate, is all the decay, or if you're leaving some deep decay, that's another course, are all the margins clean, and is all the superficial decay removed? All done with basically fluorescence. Sopro Life by Acteon, Spectra by Air Techniques or Dur, and the Diagnocam all operate in this wavelength. But I want to put the whole evening together with one device. And I think this is the breakthrough, because in my career, when I'd be talking about fluorescence and caries view, people go, well, I only want to buy one, because that's how dentists think. I only want to buy one. Well, here it's all in one. And I'm going to equate it to what I call the wheel. The wheel is what my hygienists work on 1 hour. And in that 1 hour, a significant amount of their time is spent on clinical screenings. The majority of dental offices still use a probe, an Explorer, and 2D x-rays. That's their clinical screenings. What I would recommend is enhancing your tooth diagnostics by adding 2D AI and DiagnoCam. In a hygiene operatory, as soon as the hygienist takes the x-rays, they automatically come up with 2D AI. There's no time issue. With DiagnoCam, I can basically scan an entire mouth, just clicking away or scanning, looking for any issues in less than 2 minutes. In less than 2 minutes. So the key is finding efficient ways in that hygiene recall hour to maximize your diagnostic skills. So here's a new patient, no stick. You've got your black and brown staining, and you've got some white opacious areas. One is on the mesial of the marginal ridge. 2 is right by the fissure. There's your fissure decay. Let's put a little fluorescence on this. So now you can see the porphyrins light up, and you can see the 2 fissures are quite different. Let's transilluminate them now. This is just 1 click. So with 1 click now, what's our takeaway tonight? I've got occlusal caries here. Why? First off, look at the darkness. I know it's penetrated in all likelihood into early dentin. You start to see a little bit of caries spread. That's the grayer area. When you look proximally here, I would absolutely use 2D AI to confirm this, but it looks like I've got what I would call E2 demineralization. If it's D1 based on the x-ray, then you've got to make that call. So maybe curodont repair is the answer, or an MO composite. In this area also, you can do a curodont repair. I don't believe in sealants because sealants leak. I've seen that throughout my career. So I would just follow the curodont repair protocol, clean the area, etch, and place curodont. Another tooth. Really don't see anything. Fluoresced, all with 1 click. And yet now, interproximally, I have a D1 lesion. I again would compare it to 2D AI, and I'd be doing a DO composite. But again, you don't see anything. You don't see anything. Transillumination in this case was the key diagnostic tool. This came from my partner, Tony, 72-year-old in our practice for 5 years, asymptomatic tooth number 19. She's 72 in relatively good health. With 1 click, this is what I can get. You get a great image. You got to get a great image to start. So I've got multiple cracks and phrase lines. Same click, just turn my camera around and I wanted to capture, or he wanted to capture the craze line or the crack. In this case, it's a crack. Here's the fluorescence. And you can see the porphyrin staining in the grooves. Here's transillumination showing cracks and decay. Let's take a closer look. The decay is all that darkened area in the red. The cracks or craze lines at 72, you're going to watch this if she's in good health. And in my practice, no. She's got 15, 20 years hopefully to live. I don't want this to turn into a root canal and a crown. So whether I can do an onlay at this point, that would be my goal, or a crown. And if she wants a bridge, then add it to the discussion. But all of this information in 1 click, and it's stored in your software. Last case, 67-year-old Bruxer, negative on a sleep test, hasn't had restorations in years. Presents with a fractured distal lingual cusp. No other issues reported. So this is Pearl. Pearl works with icons. So if there is calculus, it'll be blue. Incipient caries is yellow. Progressive caries is pink. And obviously I'm going to highlight now. Let's open this one up. So here's the Pearl view. Okay. Just 2D AI. Now what I'm going to do is I'm going to use, with my 2D AI, I'm going to use DiagnoCam. So here's my 3 clicks, 1 click, 3 images on 19 and 18. Look at 2D AI and look at these 3 images on number 19. You can see the recurrent decay. You can see the composite repair of the amalgam there. The patient's conservative. You can see the stained margins, and you can see the recurrent decay. You're going to do either a DOFL composite if that's what the patient wants, or a DOFL onlay or a crown. Number 18's been treated. It's fine. Let's go to the upper. Number 15, number 14. As you look at number 15, the middle transillumination slide, you can see decay around the amalgam. You're not going to want to watch that anymore. 14, look at the transillumination. You don't see anything really dark with those brown stains. So what are you going to do? On 14, you're going to observe it and place a varnish. On 15, you're going to replace that restoration with a composite. And then what you're going to do is you're going to do selective caries removal. What does that mean? I may not drill out the bottom 1 millimeter of that amalgam. And that's a whole nother course, but I don't want to pulp out because the Pearl is showing me I'm 0.6 of a millimeter from the pulp. Easy enough to make a little mistake and see that little red dot. This is all in one recall. So here's his 2D AI image. On the right side, tooth number 2, ugly amalgam in there for years. I don't see recurrent decay. I see some caries lines in the middle transillumination. If this patient wants to follow it, we'll just, again, follow it. This is all non-radiation. Tooth number 3, again, suspicious brown, low incidence of caries. What am I going to do? I'm going to observe number 3 and number 2 will be an occlusal composite or observe and varnish. Last slide. I know I ran late. Bear with me. Lot to share tonight. Lower right. Look at tooth number 31 on the x-ray. And look at the recurrent caries around the amalgam. You can see it in the fluorescent imaging, and you can see it in the intraoral image. Number 30, again, look how diagnostic this is. This is not a tooth that you have to drill at all. There's no guessing here based on that 1 click. So number 30, I'm going to observe and varnish. 31, I'm going to do a DO composite or cuspal coverage. Basically telling the patient we're going to see when I take out that amalgam and the cracks. So the goal of tonight was to really share with you how really efficiently we can really up our diagnostics using obviously vision with video and intraoral imaging, transillumination, and fluorescence. Still using 2D AI, not putting any of that aside. But when you up your game, you're going to diagnose more accurately, you're going to treat more accurately, and you're going to be able to prevent with less subjectivity along the entire boundary here. So I really have to say that to me, these are all game changers, and you will continue to grow value for your patients and grow your practices. Because the bottom line is, if you tell your patients something, they're going to forget. Premise 2 is if you show them, they'll remember. If you involve them with everything I've shared with you tonight, they will understand and they will want this work to be done. This is how you build trust with your patients. I want to say, first off, thank you for everybody attending tonight. I know I ran 5-10 minutes long. I really appreciate your workday you're sharing with me. I know we have 250 people on this course. I would love you to join me. I know I've got some Toronto people. I'll be at the ODA. This will be part of our course at the ODA. And we'll be taking a lot of this material across the country in live courses. And I'm going to have Sophia, if there are questions, I would love to answer. If you have questions, write them down, not write them, type them in the box, and we'll go from there. Thank you, everybody.
Our first question is, I just installed the software on Friday. Is there a step-by-step how I can access? Also, CareView shows tooth number. Can we number teeth with this?
Yeah, so I'm going to have Trevor, my technical guru, answer these questions. Trevor?
Thank you, Dr. Graham, and thanks for the question, Dr. Corson. Good to hear from you. So the Carry View that you used in the past was built specifically for DEXIS software. One of the benefits of Diagnicam is that it's open platform, so you can use it on most imaging softwares, but that means we have to run it through what's called a Twain, and then you import the images from the Diagnicam into the software, and your tooth assignments happen on the for example, the DEXIS side of it. So after they come in, you have to select your teeth. We do have some guides about how to make that a little bit easier.
How do you know the decay is not active under the amalgam?
In the images that I showed, for example, with transillumination, it showed that there were caries, or we'll call it more demineralized tooth structure around the amalgam. So obviously, we have at least further decay that's occurred. Is it currently active? I can't tell you I know that. I can tell you that if you don't want to drill and you see something early, you could transilluminate the tooth 6 months or a year later to see, is that area larger? That's one way. On x-rays, what we often look at is, if we're comparing, and we've all done this, you can see a bite wing looking worse a year or two later, we know it's active. Same in transillumination in the slides I showed you. So again, you can do cross comparisons. Pearl has a way of pulling up year over year x-rays so you can compare. And if you see further decay or demineralization, that's how you would know your decay is active. Just that's how I would go with it. But if I have an old amalgam and I see all that graying, I don't feel it's aggressive dentistry to take all that amalgam out, that decay that's now underneath it, and rebuild the tooth structure, hoping I don't have to do a crown. Keep going, Sophia.
What about Canberra, caries management by risk assessment, patient's risk assessment, diet, hygiene, etc.?
So to that question, it all fits in there. 100% it fits in there. So if I'm, for example, doing Curidont and a patient's drinking 6 Mountain Dews a day, you're going to have to correct them on all the acidity that's going on or all the sugar they're consuming and their diet. There's no question about that. But let's talk about Canberra, Sophia. What's going to be better? You're going to drop a class 2 box in an area with early decay that's only going to break down in a high-risk patient, or treating a patient with Curidont and then following up with specific home care recommendations. I couldn't believe, I'm 100% supportive of Canberra. Everything I'm sharing with you tonight is how to diagnose better, customize your care, and then start preventing what I would call recurrent issues by addressing, obviously, diet and home care. We know that genetics plays a role. All of these things are how you up your game than just picking up a drill and just drilling all day long. Next question.
One of them is a statement, is so glad I finally found someone who has tooth preservation as much as I have and used all the toys you have.
Well, I applaud you, because then we agree. After 40 years, it's just great to see all the things that we can all be doing together. Thank you for that comment.
Will a tooth with an occlusal amalgam that is leaking silver stain cause the transilluminator to be darker?
I don't think, let me just be clear, it's not the silver stain that I'm concerned about. If a silver filling or a composite is leaking, around a composite, you will see, like I showed you, that margin turning red. So that margin is leaking. Now you could potentially just burr out that margin and repair that margin to stop the leakage. With an amalgam, obviously, if you have micro leakage occurring, and you get a corrosion effect with amalgam, which is self-healing, but if you see an underlying area that shows decay, I would just absolutely take out the old amalgam and replace it. I don't think it's the silver that's my concern. It's more the micro leakage that's going into the tooth structure.
Are you able to use a transillumination to view the interproximal decay under a crown or composite filling?
No, that's why you'd use it. You'd use absolutely for recurrent decay underneath a composite amalgam or a crown, you need an X-ray.
There's a doctor who wrote, "My results are exactly the same as yours," in New Jersey. He's received insurance reimbursement as the X-ray codes now include imaging, especially if they're retrievable from software. He would like to suggest non-traumatic treatment with air abrasion or erbium lasers, no possibility of fracturing. Great webinar, Lou.
Thank you. And listen, erbium lasers, I mean, we're talking about a doctor who's walking the same walk. It's about not using burrs that create the enamel microfractures. That's what he's talking about. In fact, and I'll just say this, even though Cavo is a handpiece company, they make alternative devices, whether it's air abrasion, sonic type instruments. So I 100% agree with that doctor. But again, you got to diagnose first. And I think the better we diagnose for our patients, I will tell you, show and tell is just a home run. Hygienists love it and our patients love it. Next question.
Cavo told us that if there's some still plaque on the tooth, then that they still shows up as red with the fluorescence. Is that correct?
Let me be clear here. And I don't want to dive deep into this. When you're taking out caries, you have to keep a zone of remaining dentin thickness. And the literature shows it's 1 to 2 millimeters. So if you're going to leave some, we'll call it affected dentin, and I won't even get into infected, you just got to make sure your margins are totally clean. Your dentins, your enamel margins are clean. And I'd say about 2 millimeters soup around the entire dentinal area. So I don't believe in stains. I just don't, because I think they give you false positives and false negatives. In using this device, it will help guide you to caries removal. How you want to finish your caries removal, that's up to you. But I know, Trevor, if you want to answer that, routinely, I use the red as an indication to remove whatever I can without coming near the pulp. Anything from your Cavo research?
You nailed it, Dr. Graham.
Okay, great. Sophia, I've got to be respectful of time. So I want people to try this instrument out. Once they do, they're going to understand it. So I'm going to have Trevor come on and talk about the opportunity to work with his team and their wonderful reps to get demos to really start to understand how important this device is for all of our practices. If there are more questions, you can email them, and I'm just going to give everybody my email, and I will follow up. But my email is lou@catapulteducation.com. If you have more questions, just email me at lou@catapulteducation. If you want a PDF of this program, I'll send you a full PDF, and this will be recorded. Hey,
Just
Trevor.
a couple more questions, if you guys don't mind.
Okay.
Not at all.
All right. How do I sequence the application of Curodont when I'm doing a DO and I see the neighboring tooth has a lesion I can treat with Curodont? I don't want the Curodont to interfere with the bonding and etching on the tooth I am restoring.
Okay, so what I can tell you is you have to do your restoration and complete your restoration. You must do that because with Curidon, the way you do Curidon is I would just clean that proximal area, just clean it. Complete your class 2. Then what you will do is you will then etch interproximally afterwards. You will take unwaxed floss through the area so you can etch the area, wait 20 seconds, rinse. Then you apply the Curidon from the lingual and buccal. Just squeeze the new applicator from the lingual and buccal, and then simply dismiss your patient and tell them no eating, drinking, or spitting for 30 minutes. You cannot apply the Curidon and then do the restoration because you'll be rinsing away the self-assembling peptide. That's what Curidon is. You must wait till until after you finish your class 2. And at the end of that procedure, if you have to use some astringent, stop the bleeding, then go back in and etch, floss through, and place your Curidon. Next question.
Good evening, and thanks for this nice presentation. What percentage of wrong diagnoses, false positive or false negative, you got in your office? What does literature and research show about it?
Well, the literature, I try to present unbiased literature tonight. The literature shows no matter what, 2D imaging with AI will give you better results. Are there still false positives? Yes. Are there still false negatives? Yes. The literature shows about an 86% sensitivity rate. With transillumination, I will just tell you interproximally, I would just tell you for the 10 plus years I've been using it, if you use it correctly, you're going to see a lesion or not see a lesion, period. On the occlusals, yes, there's a little judgment that you're going to have to make based on the darkness along with the fluorescence. There is a little bit of judgment. But again, an x-ray is not going to show occlusal decay. An explorer is not. So you're going to have to use your mind and your eyes, but understand that that darker transillumination, that area that is really dark in a fissure or laterally around that fissure, I'd be going in. And if it's not that dark, I'd be Curidoning.
How does amalgam tattoo show up with the transilluminator?
I would assume the amalgam tattoo that the doctor's asking is on the tissue. I'm not worried about amalgam tattoo. If you want to use fluorescence to evaluate amalgam tattoo as a lesion, then you're using Velscope, which is also a fluorescence. But I'm not using transillumination or fluorescence from this device really to evaluate oral tissue. That's just not what this is intended for. This is a hard tissue device.
I wanted to comment on the previous question, actually, about avoiding a false positive. This is one of the beauties of getting 3 different modalities instantly, where you can have so much context there and compare one image to the other.
Agreed.
That's all the questions for this evening.
Oh my goodness. I mean, we kept everybody till 10 to 10 East Coast time. Well, everybody, I just want to say thanks so much. Trevor, thanks for joining and having Cavo support this program tonight.